very much, Dr. Evening. Good morning, all our guests who are here for this webinar series on reengineering blood transfusion services for UHC. It is really my pleasure to be here this morning. As you have seen from the flyer, our guest speaker, our Honorable Cabinet Secretary, Senator Mutahi Kagwe, will not be able to join us this morning. So you will allow me to move straight to our presentation and immediately begin and engage in just giving us a sense of where we are coming from and where we are going with the blood services. Dr. Evelyn has made reference to our presentation last week and the fact that it was really exciting to see a lot of healthcare providers asking us questions that are relevant to our services, questions that are relevant to blood services, but more importantly, to patient outcomes. This presentation today is just going to look at where we are going and sort of the big picture, where we are coming from and where we are going, and really hope that you can also give us feedback on what it is that we should be looking at being able to deliver, how it is that we should be thinking about the blood services. It gives you a sense of, or intends to provide you with background and also sort of the future of where we want to go. Now that the presentation is here, I will then move on to giving us the sense of the presentation. I want to start on the first slide, which is really just looking at the past challenges of the blood transfusion service. We've had challenges that relate to lack of access, lack of availability, lack of standards, and largely as a country, we have not had significant, should I say, preparedness as far as blood reserves and blood product reserves are concerned. Next slide. Over the past 1 year, next slide, and limited financing, which has been addressed. Over the past 1 year, we have made various investments in the blood sector and in the blood response. We have had centrifuge preparation, centrifuges, refrigerated centrifuges for component preparation that are currently now available in 16 counties. And this was part of the discussions last week around being able to prepare components and use them appropriately. We have a schedule of where those are available so that healthcare workers can have access to those services. We also have 4 apheresis machines that are located across the country. As you all know very well, donation for apheresis platelets apheretic platelets has been largely in the private sector at the cost of almost about 40,000 shillings per donation. In this case, we are hoping that we can be able to provide this in the public sector currently at no cost and to the donors. And then we have blood banking capacity has been increased by more than 100% from a refrigeration capacity of 24,000 units to currently 50,000 units. And we have all our cold rooms functional, and this is part of why we have increased the refrigeration capacity. This means that we can collect more blood. In the next slide, we have also, over the last 1 year, spent looking at our systems and investing in various systems. Policy, I'll be speaking about the policy on donations, transfusion, and transplant of human-derived medical products. I will also be speaking on quality management services, on hemovigilance, and we've also strengthened capacity building. This series is part of a capacity building process that really looks at how we can ensure that we are providing information, that we are providing capacities and strengthening capacities for being able to work in matters blood. We've also invested in laboratory and testing services, and I'll also speak about that and why that is very important, and the results that we have seen. We have a basic M&E system, but as we move forward, 2 things have also happened. Right now, we have an M&E working group, a national working group that is looking at setting up a surveillance system as well as a monitoring and evaluation framework for the country. With regard to counties, we have strengthened our engagement with counties, and all counties have currently appointed county blood transfusion coordinators with their roles and responsibilities defined. And the reason for this, I will speak when I talk about an intergovernmental framework. And we have also invested a lot within the NBTS ourselves in terms of governance and management. In the next slide, we speak about the supply chain. One of the biggest challenges of our blood sector in Kenya has been really the issues related to stockouts. And in order to be able to avert stockouts, it was imperative that we have a forecasting and quantification process and system that allows us to be able to identify and determine what are our primary commodities and tracer commodities. And after determining those, be able to monitor those monthly. Currently, our current pipeline in terms of blood bags in stock and already in procurement process is almost about 400,000, 450,000. In terms of testing reagents, we are a pipeline of about 120,000 and grouping reagents 120,000. And we are starting already to think about procuring for the next years, and particularly as we move into the next year where we may need to have national reserves. Next slide. So of all these investments, what have been our short-term results? And therefore, after that, where do we go? What's the big picture? Our short-term results really, in terms of blood collections itself, we have seen that as at the end of October, we had collected about 273,000 units of blood and blood products, which is the highest ever annual amount per annum since independence, that has served more than just about 260,000 Kenyans who have benefited. And this is important because as we move forward, any work that we do must really be premised on a very, very strong communications campaign, rethinking and re-engaging the culture of blood donation, and so that we are able to have not only availability of blood, but also availability of products in order to optimize patient outcomes. One of the biggest challenges has been turnaround time, where you find that you'd find that blood has been provided, has been donated by Kenyans, but we have not been able to have what we require to turn around the blood to be safe for use. Because you can have blood, but until it is safe for use for patients, then you may not be meeting the goals that we want to meet. We all know very well that the moment we talk about universal health coverage, we must be able to talk about not only availability of blood, but its access in terms of safety. We also must be able to consider the fact that as we think blood, we have to think about how to optimize by having products. And all of these are not available if they are not determined safe. And safe means that they have gone through testing for transmissible infections, so that then what is available for use can be provided to clinicians, can be provided to facilities, and what is not available for use, meaning perhaps the blood is contaminated, is then discarded appropriately. Our turnaround time has consistently decreased. Our turnaround time has decreased from really a high, and what you see there is in hours. Our target for this year was to minimize it from about 80 hours, which is about 5 days of turnaround time between when facilities and satellites provide the samples to when they are given results, to 48 hours. We are already below 48 hours, and we are looking at changing this target to about 24 hours. The key way to address this has been through outsourcing a sample transfer mechanism, where the samples are picked largely by posta. They are taken to the nearest testing facility, which is the regional blood transfusion centers. And then after that, the results are dispatched via email back to the satellites. It is important to note that we are currently expanding this transfer mechanism so that we can start to pick samples directly from facilities, as opposed to just picking them from the satellite centers. And we believe this will bring our turnaround time to less than 24 hours. As we have strengthened and improved and placed additional 8 additional refrigerated centrifuges across different satellites in different counties, we have seen an increase in the use of blood products. Last week at the meeting and at the webinar series, the discussion around the use of blood products was very robust. And we expect, and our goal is that all satellites, which will be in all counties, would actually have the capacity to be able to produce components. When I talk about components, primarily I'm talking about fresh frozen plasma. We are talking about packed red cells. We are talking about platelets and cryoprecipitate. And this means that therefore all of you will be able, or the facilities would be able to access these products. I think what we urgently require now is an understanding of our clinical need by facility, by disease demographics for each population, and determination of our inventory need, because this is the only way we can actually target products to where they are needed most. So having achieved those where we are at right now, which is a big milestone and a step forward, the next question is, what do we do in terms of long-term sustainable solutions? The first is a policy framework, an intergovernmental framework for coordination of blood transfusion services, a regulatory framework. We need clearly sustained regular donations and an accountable and equitable blood banking system. And it needs to be an equitable distribution system. Next slide. So let me start with talking about the policy framework. And we then, earlier this year, started to talk about a policy. Within the context is that the ministry, the Kenya Blood Transfusion Services mandate was expanded to include transplant services. And this has included means that we need to think about the framework for transplant services. We know across the world that organ trafficking is something that has become an issue of alert, but also the fact that countries need to think about how they manage an integrated management system for transfusion and transplant of all human-derived medical products. It is imperative that this is available across different countries, although it is something that many jurisdictions in our region have really never had a good framework for. In many countries, we also find that transfusion and transplant have been integrated into a sort of singular governance or management framework. This national policy had a policy development process, because all policies must have a process that is consultative. We engaged various stakeholders, we engaged partners, our partners who work with us, we engaged partners who are involved in blood services, whether it is mobilization, whether they are involved, and we also worked with the FBOs to be able to develop this policy. We had consultative meetings with the counties, both at the county directors of health as well as the county executive members of health and the council of governors. After the development, we then had a validation process, and the validation process, which is in the next slide, has been about being able to engage the different partners again to say, does this policy articulate the desires of Kenyans in terms of how we move forward? We were guided by a group of experts whom I want to thank. I can't name each and every one of them, that sat through, read the documents, and have been able to say, this is the direction as a country we should take. The overall objectives of the policy really is to provide a framework to ensure safety, quality, efficaciousness, and effectiveness and efficiency in one, sourcing donations, but also in delivering transfusion and transplant of human-derived medical products. The policy aims to facilitate the attainment of transfusion and transplant self-sufficiency in Kenya. And I'll talk about that briefly when I come to the ways forward, because as Kenya thinks about medical tourism, this aspect of having a regulatory framework for the delivery of not only blood, but also organs becomes essential. The other item is therefore Sorry, I think something has happened to this slide, but essentially this slide talks about the key highlights of the policy. One is that blood, tissues, and organs are treated as a national resource, which therefore means that, for instance, if you think about blood, we collect blood in all the different satellites, which is available to the facilities, transfusing facilities, which are within those counties. However, we do find sometimes that, for instance, you will need negative blood type, which is not available in the nearest satellite or in the nearest center. And therefore, it is the role of the National Blood Transfusion Service to be able to identify that and then be able to facilitate the transfer of those blood products or blood types or blood product or blood component types across the country. And this is why we say it's treated as a national resource. Secondly, we are also looking at having national reserves within the regional testing center, so that at any one time, we actually can be able to say we are able to meet not only the minimum clinical need for blood for the country, but also thinking about the optimal need, which becomes essential if we talk about being able to move towards medical tourism. We are talking about enacting legislation on the management of blood and organs, and this is a bill that is currently in Senate. The establishment of a joint implementation committee between the national and county governments, and I'll speak to that when I speak about an intergovernmental framework. The policy requires the establishment of standards and guidelines for collection, testing, manufacturing, banking, and distribution of blood across all players, both in the public and private. And I think one of the challenges we have had is that the private sector players who engage or who collect blood and do transfusion, there hasn't been very clear guidelines around the regulation for that. And so these standards will be the national standards for blood transfusion services. It requires regulation for tissue and organs, and it requires the establishment of a national allocation scheme for organs, for tissue and organs, because of equitable access. Currently, as you're all aware, we do not necessarily have any scheme or any criteria that says this is who should receive what organ when there is availability first. Normally, a lot of times it depends on ability to pay. And so this is one of those areas. It requires that we protect, we have protection legislation for donors. I talked around earlier about organ trafficking, and it requires quantification and forecasting in order to have a secure supply chain. That's the only way we are going to have consistently accessible blood that is safe for use. And it requires guidance on import and export of tissues and organs or blood products. The policy also requires a biennial publishing of gazetted costing framework for the public. I think it's important to highlight that one of the biggest questions that has come up from the public, if you were to look at our Twitter handles, at a lot of the public engagement, or when we have had meetings at community levels, is the question of, if we are donating free, why is it that the costs for being treated with transfusion are so high? And the imperative for this is recognizing that there is a cost that is associated with processing blood and testing blood and products to make them safe. However, we know that that cost varies significantly across the spectrum of both public and private facilities. And therefore, publishing a costing framework provides the public with a guidance of really the kind of costs they should be expecting, or at least the kind of costs that are used in processing. Then we need to develop a surveillance and monitoring evaluation. And part of this is because we must have an early warning system, which we currently do not have, especially for blood and bleeding disorders. We also need to be able to have a reference laboratory. We do not have a blood reference laboratory in the region. The nearest one is in South Africa, and it requires, or it foresees the establishment of a reference laboratory. The policy also identifies the establishment of mechanisms for traceability and accountability of both blood products and organs, and it requires investments in human resource development. The policy envisions the manufacturing of within the blood value chain. So whether it is products or whether it is reagents, that is whether it is the output side of the value chain or it is reagents. It also requires guidelines for how we manage our data, and I'll speak about that a little later. And it also looks at, given that as a biosecurity issue, and it requires a routinely updated research agenda so that the research that is being done on blood and areas of blood, because this is an area of significant science and scientific advancements, is actually guided towards our needs as a country. The second item in terms of a sustainable approach on long-term is an intergovernmental framework. Why is an intergovernmental framework necessary? The WHO resolutions, of which Kenya is a signatory, states that member states need to have an agency for oversight and coordination of blood services, and has also expanded to organ and transplant services. And maybe we'll hear a little bit more from Dr. Regina. We also have, however, have a transition authority legal notice after we devolved health as a country through the Constitution of 2010. Blood transfusion services were retained as national functions. However, we also know that health facilities are the ones that undertake the treatment of transfusing blood. They are the ones that actually deliver the treatment to the patient. And therefore, this is a function of counties. And thus, if we are going to have a seamless ability to ensure that the blood that is collected is effectively treated and is effectively given to patients, and at the same time can be moved around as may be needed, we must have an intergovernmental framework that outlines the collaboration between the two levels of government. It will resolve, next slide, it will be able to solve the challenges of coordination. It will help reduce stockouts because we know what is available, where and when. It will help us have a point of reference to be able to make decisions where we have challenges. I think we have been recently in a case where we had the availability of blood in a satellite in a regional blood transfusion center. However, the parents of the facility of a child who was sickled were required to bring people to donate and pay 5,000 shillings for donation. There was an engagement between the facility and the RBTC. The RBTC, that is a regional blood transfusion facility, delivered the blood. Somewhere in that process, the child was not transfused, and about 10 hours later, the child passed on. Now, in this case, really, I think there may have been need to be able to say, what do we need to do? Should we start to do audits on these kinds of things? And who should be responsible for taking that kind of decision? Because that death may have been, not necessarily was, but may have been avoidable had transfusion been undertaken to that patient who was about 13 years. Also, having an intergovernmental framework allows us, gives us the ability to be able to rapidly scale up services and ensure patient safety, which is currently not safeguarded. The current non-standard and non-uniform practices can now be much more organized within the public and private sectors if there is an engagement between the different government. And we will also be able to have better capacity for emergency preparedness because at the end of the day, emergency preparedness for healthcare services is a function of county governments in counties in the public sector. So an intergovernmental framework for coordination of blood transfusion services has been developed. Its objectives are to define the scope, to identify the structures and work within those structures, roles and commitments of different actors, and be able to monitor and evaluate within the principles of ensuring that the two governments are able to work together. I think this just really tries to itemize the fact that this is one of the things that will be essential in us having a sustainable system. And the counties have been able to identify and appoint county blood transfusion coordinators who then have a role around issues related to compliance, ensuring that hemovigilance is being taken in transfusing facilities because they have the mandate and authority over the healthcare public facilities and private facilities within the counties. So I will move to the third area, which is a regulatory framework. And one of the items in terms of our regulatory framework, our focus is on reorganizing blood transfusion services. The current model of all blood transfusion services is KNBTS, then is a linear relationship, where you find that, for instance, you will have facilities that have significant capacity. If I will take the Kenyatta National Hospital, which is right next to us, has the capacities, for instance, of a regional blood transfusion center, which is collection, component preparation, and testing. However, it is still considered a blood transfusion unit because this is in its current organization is in relation to its engagement with NBTS. We are saying that the new system, which is what we are already working on and moving towards, is going to be a function-based approach that will recategorize all blood transfusion service establishments that will be referenced from BTC1 moving forward. And the functions, as you can see on the right-hand side of that table, start with blood collection services. You have those that prepare components, you have those that test, you have those that bank, and then you have transfusion services or transfusing facilities, some of which do the above and some of which do not do any collection. They just receive the blood and then are able to transfuse it. So for instance, if you were to think about facilities such as Pumwani Hospital, which would be a transfusing facility, but does not undertake collecting, testing, or component preparation, because it is important that we are able to identify services and establishments based on their functions. Next slide. This regulatory framework means that we need to have regulations that provide us with the mandate, the legal mandate, to be able to have this recategorization. In this case, we have then developed a number of guidelines identified. We have standards for setup and management of blood transfusion services and the registration of blood establishments based on the table that I have just described and how they are expected to operate and how they're expected to report. This will be gazetted for compliance. Then we have those that have to do, we have guidance, which is the guidance on blood donation processes. This will be a guidance document. Then we have another standard, which is the standard for national blood transfusion services. This will provide the standard operating procedures for banking, for cold chain, for testing, for component preparation, for labeling, for dispatch, for distribution, and of course, the quality assurance, quality control required to deal with blood services. These are to be gazetted by the Cabinet Secretary for compliance. Now, it is important to state that these standards are applicable to all providers, regardless of whether they are in the public sector or the private sector, so that blood safety is available for the entire country. We then have guidelines on appropriate use of procedures, and I think these were discussed at the webinar last week, where they focus on blood products formulary, indications and contraindications, prescription guidance, monitoring and reporting. A hemovigilance manual sets out the requirements for establishment of hospital transfusion committees, transfusion being able how to deal and report adverse events, whether those adverse adverse events are reported to KNBTTS or through the Medicines Regulatory Agency, in this case PPB. We have blood audits and statutory reporting requirements. The Manual for Quality Management Services then focuses and relies on global standards around quality for blood transfusion services, and this is also under development. And then finally, we have national guidelines for reporting requirements for blood establishments, and this will be part of what the monitoring and evaluation framework is developing and the responsibilities that have been identified therein. Finally, we talked about an equitable and accountable system. We are developing a national blood information management system. The BMIS is currently under development. It is going to be called Damu Yetu. I want to refer us to the system which is called Chanjo. Chanjo is the current system that as a country we use for being able to, for our vaccination drive. It is similar in terms of the fact that it is, the Damu Yetu is our own homegrown system. It is a system that will be able to track and trace all blood, and eventually when we have the framework for organs and tissues, we'll be able to track and trace. But blood bags will be serialized and entered into the system, and they will be linked to the blood bags and vacutainers that will go for testing. They'll be linked to, if you have bags for component preparation, quad or triple or quadruple bags, it will then be linked to the distribution system. This system will also not only locate the blood, but also allow all the players to be able to log in and see what is available in the national system, depending on the different access rights. For counties or for facilities, public facilities that get their commodities from the national system, they will be then required to do inventory. They will be entered into the modules for inventory. Other providers, such as the public providers, private providers, may be required to enter into or to register into the modules that relate to what it is that they provide. So for instance, all blood transfusion services would be required to be integrated in the module for the transfusion services. This will allow us to do several things. Number one, it will allow us to be able to identify when we need to identify blood and blood products, where they are by those who need them closest to them. It will allow us to be able to actually get to donors and be able to engage donors efficiently and quickly, and also be able to remind all of us when we donate where it is that when it is that we are due for our next donation. It will allow us to report on hemovigilance, whether they are adverse reports or just regular reporting. It will also allow us to be able to know when our blood has been tested, has been screened, and is available for use. This system is basically leveraging ICT to be able to deliver a system for the country that makes blood management efficient. Next slide. Finally, as we've been talking about the various roles and responsibilities, we have the roles and responsibilities of the national government, county governments, and blood transfusing facilities that really relate to what is availed in the Constitution, which is the policy and regulation, technical assistance and infrastructure support by national government. And for county government is overseeing implementation, coordinating quality and hemovigilance, as well as sharing blood and blood products as a national resource, and investing in funding services and equipment. And then blood transfusion facilities are implementers, direct implementers of these services. What do we see the role moving forward? Next slide, of NBTS then. We see the National Blood Transfusion and Transplant Service as a strategic enabler for blood and blood products, tissue and organs that are delivered through assigned services. Our role will be advisory on issues such as rational use. What is the national need? Where is it needed? Dealing with emerging issues. For instance, we work to develop the blood guidelines on blood management in the context of COVID, and now revising the guidelines for blood management and blood donation in the context of, for instance, vaccinations. We are looking at advisories on required testing for procedures and advisories with regard to global networks. We will also provide strategic guidance to the entire blood sector by being able to have forecasting, quantifications, basically securing the supply chain, long-term donor retention mechanisms. In this case, we are now engaging with the NHIF to see and explore options and opportunities for being able to say, what is it that is not only from the end of being able to pay for transfusion and transplant services, which is currently part of the UHC package that has just been published, but also to be able to say, is there any way we can encourage long-term donors by, for instance, being able to provide credits on NHIF on NHIF payments for long-term donors and their families. We want to be able to set up a blood stocking system, which then says if you're a transfusing facility, this is the minimum you should have at the facility, as opposed to every single time you have a patient, that's when you ask for blood. But we are saying that your laboratory should have minimum stocking levels. But what are those? And that is part of the system that we are looking at developing. And then capacity building support. We want to provide oversight. And oversight, this is around implementation of standards and overseeing, ensuring safety of the blood that is delivered, being able to do quality control and blood distribution, and of course, setting up and implementing a national hemovigilance system. The NBTTS will run a national blood center, and the blood center is really going to be focused, one, on managing and being the host of the blood management information system, the blood reference laboratory that I spoke about, and obviously we are now starting to look at bleeding and blood disorders registry. We do not have such registries in Kenya, and it is time for us to have registries so that we also know if we are talking about products. So we are talking about various components. Where are they needed most? Where should we produce most of them? When should we ensure that, what are the stocking levels for those areas? And then to coordinate and support national blood campaigns. And then, of course, research and data. So what are our next steps and how do we want to move forward? I think the first is this year, our target is 400,000 units for the country. We are slightly behind on these targets if we look at the first 2 quarters, which is July to December. However, I think that part of what we are going to be investing in is significantly looking at how we can promote donations, and we want to facilitate the establishment of 15 new blood transfusion centers that is within the counties that do not have satellites. With regard to being able to collect blood, next slide, yes. We want to look at how we can strengthen donor services. Now, in many of the blood transfusion services, clinical donor services, which are the services related to triage, donor care, donor referral, donor notification, have been collapsed with donor mobilization and recruitment, meaning going out there and doing public relations for people to come and be able to donate. And we think that those two are very different skills. One is a skill around clinical care and nursing, and the other skill is really around health promotion and public information and public relations. And so that is one of the 4 directions. We are also looking at additional satellites. We've been working with counties so that based on each satellite, they have targets, but also creating a sustainable pool of donors by having a calendar of activities. So creating calendars with new partnerships. Over the last 2-3 weeks, we have engaged Rotary, and with the Rotary clubs of Kenya, we have visited very many of the different universities, different towns, and we want to thank our different partners. We've also had an engagement with the Boda Boda Association, and we are saying, should we have 1 week every month or every 2 months where it is a defined week in a calendar year that they mobilize their members to come, because all these are pools of young people who can actually be good donors. And then we are setting up a national youth working group. We want to leverage the community health strategy and working with the community health division so that as health promotion is being undertaken and we have community health workers, the part of what they go and talk about is blood donation, and then an aggressive communications campaign. Our second immediate, on this second slide of the immediate future, is obviously deployment of the blood management information system. We are connecting 100% sites to the national optic fiber backbone system, NOFB, and but importantly, this is now going to be extended thereafter to the transfusion facilities. We have the gazettement of policy and standards that I talked about as a priority, and then we are looking at certain key performance indicators relating to our turnaround time, relating to the targets, relating to compliance for hemovigilance, and relating to securing the supply chain, especially as we move towards this upcoming year, which is an election year. And then finally, as we think about the future, where do we want to go? It is our pipe dream that by 2024, we will actually be able to raise 1 million units. Because if we have sustainable donor pools, we should be able to do it. We should have the transplant services framework, including a national organs allocation scheme. At least we should have the framework. We know that transplants are already being done, transplant services being offered both in the private and the public sector, but it is now time to have regulations. And a technical working group has been set up and is going to start meeting within the next 2 weeks before the end of this calendar year. 3-year pipeline security. We want to ensure that at any one time, we can see 3 years in advance of our input pipeline, which is our reagents, our ability to test, whether it is grouping reagents, whether it is the different platforms that we have. And this pipeline includes not only the reagents themselves, but also the commodities that go with the reagents. We would want to foresee ourselves manufacturing products, that is plasma derivatives, plasma-derived products, and even manufacturing reagents. So sort of thinking through the input and output parts of the value chain of the blood system as part of what we would see into the future. But all this is dependent on the above. One, we are able to have sufficiency, clinical sufficiency for our current needs today, and hence the need and to invest in promotion and setting up a donation culture across the country. And number 2, that we have a secure pipeline for our commodities and reagents. It is only at that time that we can think about manufacturing. To do all of those, we must have a reference laboratory that provides the highest levels of testing, the highest levels of quality control for us to be able to deliver. So I have been speaking for almost 40 minutes, and I want to thank you all very much for listening, and I hand over back to the chair. Thank you.
Thank you so much, Dr. Anduko, for that elaborative presentation that you have just taken us through. And you've actually kept your time. At this point, I see we are joined by Dr. Karioki Gishoke. He's the CEC Health of Nakuru County, which just attained its city status less than a week ago. And congratulations to the citizens of Nakuru County. Even as we continue with the discussion, this is where I will ask Regina, Dr. Regina, to come and just give her point of view, because she's been in this blood ecosystem for quite some time. As a representative of the WHO, she can speak to whether Kenya is it on its own? Is it an island? Is it doing things on its own, or it's doing best practice as practice elsewhere in the world? So, karibu sana, Dr. Regina, you have 10 minutes. Thanks.
Good morning, everyone. Can you hear me?
Yes, Dr. we can hear you.
Thank you so much for inviting me. Thank you, NBTS, for coordinating and organizing this session. Thank you to the participants who are participating. I just want to, first of all, answer directly the question you've just asked. Where is Kenya at in terms of, well, maybe first I should introduce myself. My name is Regina Mbinjo. I work for WHO Kenya, and I have worked for WHO Kenya for the last 15 years. And I've been involved with the blood transfusion system for most of that time, probably the last 10 years. And just looking at Dr. Nduku's presentation in terms of the progress and status and projections, next steps for Kenya, I have to say we could not be more thrilled as WHO to see a system that was in many ways limping for so many years. I think all of us will agree that the Kenya blood system has struggled for very many years. And we have been working and involved in those struggles and trying to make sure that that the country really realizes its potential as far as blood supply and access to safe and quality blood is concerned. And now, even better, that we are looking at issues of transplantation. So I have to say off the bat, my comments are congratulations, Kenya, for what you're doing. Congratulations, NBTS, for what you're doing. And we can only say, keep it up. We can only say you have our full support in everything that you're trying to achieve. I just want to point out a few areas in terms of the role of WHO in a process like this. As you know, WHO is a member state organization. What does that mean? That means we are a secretariat of governments who, in a sense, created WHO to work with countries to realize really that ambition of health for all. And in the current framework, we're talking about universal health coverage and universal access to both products and services like blood, like tissues, like organs, like transplantation services. So to see Kenya embracing that whole agenda is something that we are really, really proud of as WHO. Our role it takes many forms, and in Kenya it has taken many forms. First of all, it is about developing normative guidance, whether it's resolutions of the World Health Assembly, it is frameworks to guide countries in terms of establishing systems and mechanisms that ensure that you can achieve what you aspire to achieve. So when we look at what Dr. Nduku has presented, a lot of that is aligned so well with the guidance documents of WHO, and I will name some of them. Currently, we have a framework for what we are calling an action framework to advance universal access to safe, effective, and quality assured blood products. And I can see that really Kenya is following almost to the letter what is in that framework. And the reason for a framework is that, as you can see, some of the issues we are discussing, you may be heading a blood transfusion service, it doesn't necessarily mean that you are able to think alone, or even if you sit in a boardroom, you may not necessarily remember every single issue that you need to think about in terms of setting up a system. And what WHO does is then compile and synthesize guidance that helps leaders, policymakers in countries to think through a system comprehensively and not to forget things that might be critical that you may be able to do if you are aware that they need to be done. And that's one of the reasons why our guidance documents are about helping member states to be sure that they're on track when they're implementing systems like this. Now, the blood transfusion system is a tricky system to put in place, but it's also a system that can actually be a pathfinder for many other issues in a country because of its uniqueness. You're talking about a product that you have to take out of the vein of one human being and transfuse to the vein of another human being. Right there, that chain is fraught with all manner of risks, but it is also a system that enables you to take a look at your broader system in very interesting ways. There are ethical issues in terms of who are you collecting blood from. There are issues around safety. And here, just to point out some of the issues you need to think about, is there's a safety of the product itself, but there's a safety of the donor that you're collecting this product from. Who is this person? What state do you leave them after you collect, particularly when you start talking about organs and things like that? What is your relationship with that person after they have donated, say, an organ, for example? And these are the issues that we find in many countries they are not thought about. People donate an organ, then you don't follow up on the donor who now is living -1 kidney and should then, I think, deserve and require their own special care. When people donate blood, to what extent are we then sharing the knowledge that they need to have to remain safe, to remain potential donors in the future, but also to live better and healthier lives because they are contributing to what we are now calling a national resource. One of the other issues I just want to highlight, and we are happy again to see Kenya moving towards legislative and regulated systems, because this is also a very important aspect when I talk about universal access. There is the demands, there's the supply side where we are doing all these wonderful things to make sure that Kenyans have access to these things. But having these systems then captured in law and properly regulated, it is also to say you're giving freedom to Kenyans in the context of their right to health to say, yes, NBTS, you're doing well, but there's an area where I am not receiving the service that I feel I ought to receive. That is part of what we call right-based systems. So the more these systems become transparent, the more you are likely to see Kenyans demanding more from you. And when these things then are properly legislated, you're also then managing expectations of Kenyans. What is it they should expect? What is it they should not expect from the system at any one time? And for us, we can only say we are happy to see these processes taking shape in Kenya. And I can already tell you, we are having conversations with Dr. Kilonzo on how these experiences can be shared with other countries in the region. You are actually, Kenya, you are becoming a leader in this area within the region of the African region, because many countries are still not thinking about these issues comprehensively the way you're thinking. And so we really encourage you to continue in this track. Dr. Nduku asked me to comment about regulation, blood regulation, the blood regulatory system. And really the thinking is that because of that supply chain that I've talked about, the vein-to-vein chain, you're saying that you are collecting blood from an individual, giving it to another individual. That product is not any different from a medicine that you get from a factory and give it to a person to swallow. So the same regulatory principles that apply to make sure that that product is safe, in a sense, we are saying the blood transfusion system itself, which sometimes operates the facilities that collect blood, should not be the one to say definitively, we assure you that this blood is safe. They do that as part of their work, as part of the requirements of their function, but there should be an independent oversight system that can say, we check, we inspect, we look at the records, we listen to the feedback from the users, and we can confirm that this system is a safe system. And really, it's just another layer, particularly when you're talking about people's rights, that you want to be sure that when you say this system is safe, you don't have a situation where something may go wrong and it may never be known, because sometimes systems do not necessarily reveal what went wrong internally. And therefore, WHO has developed a framework for how countries can regulate blood transfusion systems to make sure that they're delivering quality and safe products. And because we're talking about a product, blood is ultimately a product, just like medicines. I think the guidance has been, if you already have a medicines regulatory authority, the government can expand the services of that authority to also regulate blood. Now, for Kenya, because I've been involved in this process for long, one of the reactions that has been there among the professions in Kenya is then to perceive that as though the PPB is regulating, pathologists and hematologists and laboratory people who are involved in blood. But really, the issue is not regulating the professional. The issue is regulating the product that these professionals are dealing with, so that we ensure that it is safe, it is efficacious, and that it is of good quality. And it then means working with all these professionals in their respective roles to make sure that we have a system that assures the quality of the product. And I'm happy to see that with a lot of engagement, there is now clarity around this issue of a blood, what we call a national blood regulatory system, which works alongside the national blood transfusion system. And this is something that we are, I think, continuing to support both the NBTS and the PPB to put in place. And it has to be something that you're working together jointly. It can never be something that you operate independently of each other. The other thing I want to talk about is the area of tissues. Again, we see a lot of adaptation of the guidance that WHO has provided. We have, for example, what we call guiding principles on human cell, tissue, and organ transplantation, which was released in 2010, actually, the initial guidance principles, but there have been other documents. And applying these guiding principles, WHO doesn't tell a country how to do something in terms of have a blood transfusion system separate from a blood tissue and organ. It is up to the country to determine ultimately how you organize these systems, but providing guiding principles then ensures that you are applying the system normatively, and you are then setting a system that is likely to help you to attain what you want to attain. There are many, many guidance documents that we have developed. There's a lot of capacity building that we do, not in Kenya because we are organized at 3 levels. We have a regional office and we have a global office. So a lot of this is capacity that comes to a country through these different levels of WHO. Sometimes I'm merely the coordinator for expertise that comes from other levels, because I am not an expert actually on blood, but I am an expert on the systems and ensuring that health systems are delivering what they're supposed to be delivering in a country. And in this sense, I have worked with NBTS for, I think, more than 10 years now. And I'm very pleased to see the work that, the shape that this system is taking. I think I'm going over my time, so I will leave it at that, but I'm happy to answer questions or provide further information as needed.
Thank you so much, Dr. Regina, for your input and your insight. Having been in the sector for that long a time, you're able to see the transition that we have made as a service, as a blood service. Even now, with the introduction of with the devolved government sort of system that is there, So, and that leads me to my next discussant, who is Dr. Karioki Gishoke, who is, as I had mentioned earlier, he will be representing the county governments, and whether as a national blood system, are we meeting the needs of the counties? How are we working from it being a purely national government activity to now a shared negotiated activity, where now county governments who have contributed so much in terms of donor care, transfusing, in terms of even when we had a bit of problems within the service, they came in and were able to buy the different commodities to make sure that service continues to be delivered. So I invite Dr. Gishoke, you have 10 minutes. Thank you.
Thank you very much, Ibrahim. You can hear me? Hello?
Yes, Dr. we can hear you.
My name is Dr. Karioki Gishuki. I'm the County Executive Committee Member for Health for Nakuru County. And I am representing Dr. Mbai, our Chairman of the Health County Executive Committee Members Caucus. We are here in Naivasha participating in an intergovernmental forum. And thank you for acknowledging that now we are a city. So we are feeling like Nairobi already. So coming back to our main issue of discussion, first and foremost is to say that we might be lucky that none of our patients is listening to this discussion, because they would wonder where all these brains have been. I live in a county which is on the northern corridor, and sometimes our demand for blood outstrips supply. And that has forced us to do some things that we wouldn't want to be participating in, like having a unit in our PGH, where we also house your regional blood transfusion center. So as county government, first and foremost, we do not have the monopoly of using blood at the counties. There are also other players, like the private sector, the faith-based organizations, and the demand for blood, as you might be aware, has gone up. What we envisage as a county is that we first acknowledge that this is a national government function, and the national government also runs other longitudinal projects which we run together. So it means we might not have to invent the wheel. I'll give an example of maybe the HIV program, the TB program, the malaria program, which works very well, managed at the national level, implemented at the county level. And at the risk of maybe sounding repetitive, I'll also give an example of KEMSA. Someone has just been talking about blood products being like what we procure from KEMSA. So we have no role in manufacturing and procuring, and we just get these things from KEMSA, and from there we manage up to the level of where our client or our patient consumes this product. So I do not think blood is very, very different. And where we are now is because of very many years of neglect of leadership and putting the right things like we are anticipating to do now. A lot of us participated in the meeting that was in Mombasa, and we were given very good information by Dr. Nduku, which we agree completely with. So what do we really want as a county? That this blood transfusion is managed nationally for very good reasons. First, economies of scale. 2, standards and safety. 3, rationalization of demand and use. And finally, monitoring, so that we run an efficient national program that the standards in Nakuru are the same as the standards in Mandera, and that people in Nakuru can get, if they want 5 units and Garissa wants 1, both of us can get what we demand, because the demand for blood also is different depending on which county you are in. I'll give an example. Some counties do not have very well established health systems. Others have, especially the ones which were former provincial headquarters, like say Nakuru, Embu, Nyeri, and such. And therefore, our health systems are more established. So if you get an accident somewhere, say in Baringo, and it's a serious accident, despite that being a county, you might have to be referred to Nakuru. I'll give you very grim statistics about Nakuru, Nairobi Highway, Eldoret Highway. We usually have black spots here. And sometimes Brad has embarrassed us. So we completely agree with what is happening, and it's good for us and should be expedited. We, on our part, where now we come to implementation of healthcare, we will do it like it's supposed to be done, but we also know Brad, unlike KEMSA products, will have to be corrected or will have to be organized at the local community levels so that it is processed and comes back to us so that we can give it or the private sector or the faith-based sector. We also would wish to participate in that. So a policy that recognizes our role in this process, but still maintains, like I told you, where we have original project like HIV and malaria, and we have no complaints about it, is a good one. Because finally, what is important to us is our client. Is he happy? If you listen to this discussion, it is academic, it's good for us, doctors and others. But for the client, the most important thing, if they need blood now, will they get it? So my submission is as simple as that. What we should completely avoid is the embarrassment of a client who requires blood at the level of the county or at the national level, even KNH itself, and that client does not get it when that client needs it. If we are able to address that, the rest of us who are now the technical people can go through all the other things, like now things like the infrastructure around it, the financing, the HRH, the health products and technologies that we need around there, monitoring and evaluation, and it will be good. Well, we've done all those technical things ourselves. Now the client will be happy because they'll get blood. And I had my submission there. Thank you very much.
Thank you, Dr. Kariuki, even for giving us the county perspective in terms of how are we meeting needs? Are we having timely responses to the blood needs across the country? As you have rightfully said, maybe the RBTCs are in our former established provincial general hospitals as it was, but now with the devolved system where we have about 12, 13 counties that do not have any blood establishment center, but there is transfusion happening in those facilities. So now it is just trying to have dedicated satellites, dedicated establishments where they are able to do the collections, they are able to do the recruitment, the mobilization, and have a donor database that can easily be called upon, especially for the rare blood groups, where you have a database that if there is need arises that blood is not available, that particular unit is not available, that particular blood type is not available, you can easily take the phone, reach out to them. It has been working, it has worked, and it's doing very well, especially in our faith-based facilities, in our private facilities, where once you have a database, and that's how the Damiyetu will create for us that database as well, where you're able to recall your donors within, if they're eligible to donate, and actually help our clients who are the patients who are in need of this particular, or of those different blood groups. We are aware, as Dr. Nduko had mentioned, that our registries, we do not have our registries. We have, as counties, as transfusing facilities, we have not quantified our blood needs. Now, I remember Dr. Musa Mohammed, the Deputy Director of Health in NMS, actually told us he has about 3,000 deliveries in Pumwani. Pumwani does not do any collection, it just does transfusion. And for the past 3 months, as the Nairobi Regional Blood Transfusion Center has been able to actually meet all its blood needs. So these are the encouraging stories that if we work in tandem, if we work together, then we are able to have more blood establishments, blood collection centers. And when we have many blood collection centers at convenience to the donor, then the banks will have blood at all times. So we are not having stockouts in terms of blood. We are quickly able to redistribute this blood, especially the ones that have in a short expiry, because that county was not able to utilize all that blood that it collected. And because blood is a national resource, then we are able to redistribute it. We know that places that are as vast as the Turkana County or Marsabit County, with other factors, other variables, including insecurity, ravaging droughts, very low density, population densities, poor nutrition index, may not make that particular population eligible, have quite a number of eligible donors, but doesn't mean they don't need the blood. So it is, how do we then redistribute? If Dr. Kariuki in Nakuru County is collecting more than he needs, then how do we then move the blood, the units of blood or components prepared to those sort of populations? And that is what the Kenya National Blood Transfusion Service comes in as a strategic provider, and making sure that then we are meeting the blood needs of a country. So with those comments, I will invite our participants, who now are more than 400 of you. We started off with about 100, now we are close to 450, where to just make your inputs. I see quite a number of questions in the box, in the Q&A box, which we'll go through. I will start with, I saw a question about from Mudhoni. Is there anything else people living with NCDs can do to help other than blood transfusion and organ donation, since they may not be eligible to donate, yet they want to help out, speaking as a past regular blood donor who is no longer eligible to donate? Dr. Nduku?
Sorry, I was just going through the various questions as they are coming in. I think one of the questions that one of the attendees has asked is, we are training for the private sector because we've had interns from PSC, and I just want to say that we have re-engaged the PSC process, and we certainly will be looking at how we can do better on having internship help us really by being able to try and absorb. As you are all aware, there are regulations around PSC and absorbing of staff. The other question is, thank you very much, Mwenda, for your comments and appreciating us. I think the other comment is on the inclusion of therapeutic apheresis, an RBC as part of service offering under MBTS, especially for patient groups like sickle cell disease in all the counties. And I said, yes, that is a plan. Right now, we've only placed 4 apheretic machines, apheresis machines that are doing platelets across 4 regional blood transfusion centers. Those are the ones that are currently in place and working. We are looking at making an additional 4 within this financial year. And then after that, we have to keep expanding slowly. We don't have the resources to avail in every county or in every satellite at the moment, but it is certainly something that we are thinking about. Is there anything else that people living in NCDs can do to help other than blood donation because they may not be eligible to donate? I think this is something that I'm not sure I have a good answer to. I would really like to hear from some of the other participants as well as yourself, but certainly in terms of being able to help mobilize people to donate, help speak out about donation, help get communication out there, sensitization, I think is one of the biggest things that anybody can really help us. Do we have plans for implementing these programs at regional level? that is at ESC, and looking at biobanking, gene registry, and plasma processing. I think that, as I said, that currently our focus right now is being able to have our own clinical sufficiency for blood, because we are still not there even with the increase that we have. Maybe I might want to say that, for instance, in the first quarter of this current financial year, that was July, September, we met just about 80% of the clinical need required. That is as NBTS. We know that a lot is being done in the private facilities. Having said that, once we have met our clinical need, then enhance the investments in communication and mobilization, we will then start to look at whether we can meet the need that is, whether we can then move towards higher levels of sufficiency, inventory need, and then have more that we can go into product manufacturing. With regard to biobanking, we have just acquired one biobank for the National Reference Laboratory, National Testing Laboratory, and certainly we will be thinking about how we move that forward. On matters gene registry, I will not say much other than say that I would expect that the technical working group on regulations for transplant services will give guidance on the matters of developing a registry for gene registry, because I guess that is where we will get guidance on matters gene typing and so on. And then finally, on plasma processing, that's part of the manufacturing. As you all know, to do plasma processing, we need significant amounts of blood, and therefore fresh plasma, which also in turn goes back to being able to get a donation culture, regular donors in high numbers. And hence, that is why for us, that investment is so essential, because it's the only way we are going to have these plans. Are they going to be at regional level? I think we could say that once we do implement our foreseen future of having a manufacturing plant, then we would be able to say that we can manage to engage the region, or we can provide for the region these services. Part of the reason and part of the thinking behind having the requirements for policy in the policy document around guidance on import and export, and I think this was alluded to when Dr. Regina talked about the fact that we need a regulator, the medicines regulator, to be able to guide this, because this would fall within the space of regulation of import and export of medicinal products, in this case being human-derived therapeutic products. Then we would have to think about how that would be done. But that is something that is in the future. So the answer to that question, do we have plans? Yes. A centralized quality control of products collected and issued to patients, and technical education support to transfusing institutions in terms of EQS. I think the answer to both of those is yes. One of the things I said is in our immediate future is to strengthen the national quality management system, and this includes both quality assurance for processes as well as quality control, both for the production processes and products themselves. And I think we've also been guided about having external QA for ourselves as a provider and an institution. To Dr. Nduko, what plan does the program have to improve BTs at the lower level? That is training of healthcare workers, supply of equipment, and this is from West Pokot County. I think I would say that we have already, this series is part of the initial, one of the, should I say, avenues for providing information, sensitization, training to healthcare workers. But we will continue. We have a plan that we have laid out, and we know that quite a number of equipment have been provided to counties, including, I believe, West Pokot have received equipment in the last 2 to 3 months from NBTS. I would actually ask Dr. Evelyn to confirm this for storage of blood, and I think even for processing of blood components. And therefore, this is something that we are working on consistently because we are looking at 1, need, and 2, capacity. And we have already done assessments for additional equipment distribution. It's very important that whenever we distribute equipment, that it is actually used, and therefore training is part of what we are focusing on over the next few weeks. And then I want to, Dr. Violet notes that the law in Senate does not deal with organs. Yes, that is correct. It only deals with blood, and the law in organs is provided in the Health Act, and are waiting for the Cabinet Secretary to develop regulations. This is correct, Dr. Violet. I'm not sure how I stated it, but the working group that will develop regulations, and these are the regulations that will be gazetted, and we expect would be gazetted by the Cabinet Secretary. And then the policy will also have to speak to the law and be harmonized, including the standards KNBTS is developing. And yes, we have been ensuring that all of these are aligned. And then finally, we are very proud of the direction and leadership of the NBTS. Thank you, Dr. Maturi. As a regular user of blood, I'm happy that you're saying that the Nairobi team, if the Nairobi team is online, you have received the kudos. Then the question is a nutritionist working at KNH is blood transfusion requires involvement of all professionals, nutrition not included, and logging as others. I think your point is well noted and taken, and we'll make sure that this is the case. There are higher uses of blood and products, children with large spleen sickle cell disease, explore fast tracking managing of this. I would like, I know that Evelyn is the moderator, but I will also ask her to make a comment on how we can explore fast tracking of this, especially. I think there are some proposals around surgery. And then there's a point that the current law talks on issues of rights and donors and issues of safety, import, export, and the law makes NBTTS a saga, which is important. Thank you very much for that note. That is correct, Dr. Violet. And then I think there is also another point from Rocky Asante. I think you're doing well in Kwale. And you have talked about the role of counties on blood, which is distribution. And one of the health challenges you have talked about is anemia. And I think we all agree that there are some diseases that we have to keep thinking about, and hence the need to do a projection of our clinical needs if we are going to identify where different products are needed most, based on perhaps even already the epidemiology of different diseases and conditions in different areas. I would like perhaps to refer the question related to the East African region to Dr. Regina, and if she can make a point on any of the other questions. Thank you. Over to you.
Is it?
Go ahead, Dr. Regina. You kindly unmute. Yes.
Yeah. Thank you so much for this opportunity again. There are many issues I may not comment on because issues that have to do with what is the NBTS planning to do, as WHO, we would not comment on that. But we would encourage and be fully supportive of efforts that advance, I think, the guidance that WHO provides. On the issue of expanding some of the issues that NBTS is doing and some of the functions that are now coming to fruition across the ESC, I would say yes, not because there's a plan to do so, but because in principle, as I mentioned earlier, WHO is looking to what Kenya is doing to identify opportunities to scale up across other countries in the African region. Therefore, good practices, lessons that we are learning from Kenya, capabilities that Kenya is developing that WHO can sort of ride on to support other countries in the region. Absolutely, this is something we would be more than happy to explore with Kenya to expand. So that is how I would answer that question on East African community expanding. The other thing maybe I wanted to point out is on the issue of transplantation, and to say that as we develop the system on transplantation, one of the things I've seen as we engage as healthcare professionals in Kenya, it's very, very important to step into the shoes of your patient, of the person who donates an organ, and to be sure that the systems that we are developing, and as you support and comment on them, that you think both of your perspective as a healthcare provider, but also the perspective of the recipient. And sometimes it's quite easy not to always have the full view of what the recipient or the donor of an organ, for example. And I say this because one of the comments I saw is about cadaveric donations, which actually is captured in the health law, and even other matters of organ transplantation. That one of the reasons why WHO develops the guiding principles, and they are available on the internet, but I'm happy to share with you, is that there are certain subtle ethical, not just the technical issues, but the ethical issues around, for example, cadaveric organ donation. Let me give you an example just to make the point. In the guiding principles for WHO, one of the things it says, guiding principle, I'm just looking at it now, guiding, because it's like about several guiding principles. There's one on, and I want to read it out. Physicians determining that a potential donor has died should not be directly involved in cell, tissue, or organ removal from the donor or subsequent transplantation procedures, nor should they be responsible for the care of any intended recipient of such cells, tissues, and organs. Now that's a guiding principle, which by the way, when WHO produces documents like this, we don't sit in an office in Geneva or the regional office and develop. There are engagement mechanisms with member states, so that what comes out is the expert guidance based on the issues that have been observed in the world and the knowledge across the world in terms of how these issues should be addressed. So as you can see, this is not a matter of capacity of a physician to do cadaveric transplantation. It is the principle of ethics, that there should be separation of roles between certain people. Now, this may not always be possible, but this is why it's a guiding principle. As you develop these systems more and more, these are some of the areas that might become problematic in future if they are not addressed right off the bat, even in terms of how your laws are written and your regulations, so that we apply principles that have to do with how we also protect the rights of people, the possibilities of conflicts of interest as we provide services to people, that these are upheld in the laws and the policies that we develop as a country. So this is what I want to say about that. And I can only say we are happy that Kenya is not rejecting these guiding principles. They are actually being embraced in all the sort of policies and laws and guidelines that we have seen, and we want to really encourage that. I think I'll stop there, unless there's a direct question that I can answer. Thank you.
Okay, thank you so much, Dr. Regina. To Dr. Kariuki, this issue as brought out by Boaz in terms of how do we improve access to blood transfusion services at the lower care level, perhaps you can speak to it as well.
Okay, very well, thank you. Certainly, as you know, clinically demand for blood is driven by the circumstances that are in the implementing facilities. And you know that in counties, we have a referral systems. For example, at the community level or at the dispensary level, you might not expect any transfusions, and at least from the level of a health center, maybe that is level 3, level 4, and level 5. So certainly you might be aware that in the last 10 years, there has been a very dramatic improvement in the healthcare service provision in the counties. And therefore the demand also for blood and blood products has also increased. You might also be aware that there has also been a dramatic improvement in the numbers of the human resources for health that actually provide the services that leads now to the demand for blood. So how we improve access to people who require blood is by actually improving the healthcare services that we provide at the counties. That might sound general, but it actually sums it up all, because the more referral facilities we have, the more operations we are able to do. And I'll give an example of a place like Nakuru, where I come from. If you go to our main hospitals like Gilgil, Naivasha, Nakuru, and Molo, we have more surgeons, we have orthopedic surgeons, we have extended the range of services, and that means we are able to do more operations and handle more maybe accident and emergencies, which means an improvement in blood. So the demand for blood is driven by the other side of the market, which we want to meet by meeting the services that our clients require. I hope that is good enough.
Thank you so much, Dr. Kariuki, for your response. I see Dr. Fatma Abdallah is on panel as well. Perhaps she can respond to this question asked by George Motama. There are higher users of blood and blood products in children with large spleen sickle cell disease. Can you explore fast-tracking managing some of this disease, some of this to reduce the number of higher users? Go ahead, Dr. Abdallah. Doc, you have to unmute. Okay, I know she wasn't part of the panel today, but I was happy to see her on the call. But this George is there where we have special products. Instead of giving the whole blood to our sickle cell disease patients, we actually give the PRCs, which have less antibodies or other antigens that may cause the allogeneic immunization, as discussed last week by Dr. Abdallah. Yes, the surgeries or other interventions, other medical interventions are currently happening. I'm not sure I've understood what we mean by fast tracking. Is it they undergo surgery at a faster rate rather than having the more conservative treatments with the medicine or through multiple transfusions? But we have different products that can be able to serve these particular populations. the issue about CPD, maybe Mwenda and the team in the Kenyatta platform are able to respond to Douglas, as he has indicated that he's not been receiving his CPD points. So perhaps maybe you can send an email to the Kenyatta Medical Research Team. They are very responsive. I see a few participants with their hands up. I see Dr. Sylvester Mainge. I will unmute you shortly, and you can go ahead and have make your contribution. Doctor, you go ahead. We have unmuted you. Doctor, you have to unmute on your side as well. Are you talking? Perhaps then you can type in your question, because we are unable to hear you. I have Romana. Go ahead. Wow. Romana, go ahead. Then I have Dr. Christine Saida. Saida, please make a contribution.
Hello, thank you very much. I hope I'm being understood.
Yes, we can hear you, Doc. Go ahead.
Thank you very much. Let me express my sincere appreciation to the sessions that took place last week and this week. Very enlightening. I would like to congratulate Dr. Nduku for a work well done and the leadership. This is what leadership does. We can see within a very short span of time, we are getting some sanity back into that system. Dr. Nduku, congratulations and your team. I would also like to congratulate one of our board members who is also supporting Dr. Fatma Abdallah, who did an excellent presentation last week. And we are very proud as Kenya Medical Women that we are associated with Dr. Abdallah as one of our board of directors. Thank you very much. And Nduku, thank you for being a friend of Kemo as well. Now,
Thank you.
My 2 points. One is the systems issue that Dr. Regina of WHO has spoken to. I think just looking at the interface of how then the certification that the blood is safe, the safety of the blood, then getting it back onto your DAMU system or our electronic capturing system is something that we need to think about. The second thing, which is small, but I will talk about it, is how are we now mopping up the implementation, looking at strengthening the system at the implementation units? Because this morning we have lost a baby at Kenyatta. And fortunately, people may think that Kenyatta really is foolproof. But because of blood that has been asked for the family to donate for the last 3 days, I know there has been a shortage. But surely we need, as even implementing units, and I think for BTS, for KNBTTS to work with this unit so that we full bulletproof. Where are the major risks where blood will be needed immediately for deployment? I think there are nuances that we need to do at the implementing units so that we avert loss of mothers who are delivering and their babies. That is something that I would like to flag out. As we are being told, Nairobi is self-sufficient in Pumwani, we are seeing loss in Kenyatta National Hospital. Some of them are ethical issues like Regina has spoken about, and we really need to speak to our hearts and say, what can we do better as practitioners? And I think I would leave it at that. But Dr. Nduku, there are points of ethics that perhaps we need to bring to bear. There are several laws that are not speaking to themselves. Like, for example, I would want to ask one for the gamete harvesting and giving when we are supporting women who are IVF issues. if we need to talk about ethics around that and taking that as a tissue that is coming from human that needs to be protected and to be managed, I think we have huge issues there. And I want to leave it there. I just wanted to congratulate you and flag areas of strengthening that may be required. And some of us, because we have elaborate papers that we have done, including research of international human rights documents that have come around those areas, we would be able to maybe provide them for you to maybe give it to your technical team as they begin to work on that document. Thank you very much and congratulations once again. Thanks.
Thank you so much, Dr. Sadia. Dr.
Thank you very much, and thank you, Dr. Sadia, for your kind comments to us. Let me start with the question around at service delivery level. I think this is one of the areas where we need to engage further with institutions. What I can say at this point is that at the NBTS, and particularly the Nairobi Regional Blood Transfusion Center, we have sufficiency for the needs that we have. And any request that comes to us, including from Kenyatta, has been met over the last few months. We do not have places where we have not met. And when we haven't, it is usually perhaps a blood type issue, which we immediately then, because we have an internal operating system, find out where that blood type, as we all know, negatives are not always available all the time everywhere. We then mobilize it and bring it to where it is needed. So perhaps maybe the question will be a question to Kenyatta around strengthening the systems, but I hear you. We will also look at how we can better support and engage with Kenyatta. On the question of the issues related to some of the tissues, such as matters related to gametes that you have just mentioned, I think there are two perspectives here. The first perspective is that when we talk about the regulations, they're going to be very generic regulations that look at all tissues and organs. And then we are going to have different, very specific standards or guidelines and that speak to the different, very specific areas. In this case, the issues related to gametes and reproductive health will be handled by the Reproductive Health Division of the Ministry of Health, because I think there is a whole already existing framework that has even been discussed around matters legislation, which means that we'll have to be able to engage with them. But for now, really, the first question is, what is the overarching framework? And thank you very much for saying that you can provide us with additional papers that will allow us to be able to get as much information as we can from the global community and from knowledge that will help this working team. I think that is all for the two questions. Is that it, Dr. Evelyn?
Yes, that's it. I see Rocky asking, is making a request to National Office to come up with certification exercise for counties to declare them to be blood sufficient as per the WHO criteria to encourage counties working hard to reach blood sufficient status. Any comment on that, Dr.
I think when we talk about, sort of certification or clearance and sufficiency, I think there are two sort of different directions. The first is the question of sufficiency, which is the question of meeting targets. And then the second is safety and effectiveness, which is the question around, yes, you have the blood, but is it available? Is it safe? And I'm hearing that both of them, from Rocky, we need to think about both of them. Then the other perspective I'm hearing is the question around how do we, create an enabling environment and even incentives for counties that are performing. And so that is noted. I think it's something we would need to discuss. What would that look like? How would it look like? And how would it be implemented? So we take note, and it's something to work on. Thank you.
Okay, thank you so much, Dr. Nduko. We have, I think, a few minutes to take one more last question. I'll ask Festus to introduce yourself. Let us know where you're logging in from, and go ahead and ask your question. Please kindly unmute yourself. Are you able to do so? Okay, I see you're not. Then I will ask Florence. Kindly unmute yourself and make your contribution. Florence Mudwi. Okay. Philemon Bowen. Let us know where you're asking your question from.
Good morning, team.
Yes, go ahead, Philemon.
My name is Philemon Kibet Poen. I am a medical laboratory technologist working within Nairobi. I had been trained by Kenya National Blood Transfusion Services last year as an intern. I finished my 1-year internship this year, April. I am currently practicing with the private hospitals in the Department of Hematology and Blood Transfusion. My question would be in terms of quality assurance and quality control. Any other private facilities, most of the privates that I've been working with are using serological testing kits that perhaps compromises the quality of blood products that might be transfused to our patients. So my only question would be, is there any way that our Department of National Blood Transfusion Services can regulate private facilities and offer them licenses in promoting or producing and making of blood products? Thank you very much.
Thank you so much, Bowen, for your contribution. I will take one more and then ask Dr. Nduko to close for us the meeting. Florence Mwachori. Just let us know where you're logging in from and then make your contribution. Are you able to? No. And Evans Odhiambo.
Hi, everyone.
Hi, Evans.
Okay, I'm Evans Odhiambo from Garissa County Referral Hospital. I'm a laboratory technologist. So my main concern or addition is that I find that most of the private sectors, as we had, people are using rapid test kits for screening blood. And for me, that is wrong. And these people, they need to be arrested if I'm not wrong, because for rapid, we normally use it for diagnostic, but not for screening. Then in Garissa, we have only one satellite. Then what I can say that we really thank the national team for their support, because at least we are getting some items. But now we are the only place which distribute blood within Garissa, even sometimes for those patients in Ola. So how can we help this group? Because what we are getting is not enough. Then we normally rely with the relatives to replace blood, because blood campaigning here again is a little bit challenge, because most people, they fear donating blood. So if you guys can come up with at least some ideas to assist us to boost our stock here, then we do appreciate to normally get the screen blood on time. The only problem we are facing now is getting the product. Let's say we need the platelets. Now getting it is not that easy. We only rely on the Nairobi team to assist us. Maybe then they can find that the patient is in critical condition. Another thing, the fresh frozen plasma, again, we can't have it here. Our teams, our facility, so still ask for your support or the way forward that we can handle this. Otherwise, We really appreciate your work and will continue working together to improve the life of our society.
Okay. Thank you so much, Evans, for that contribution. Dr. Nduko, as we have 3 minutes, less than 3 minutes to the top of the hour, go ahead.
Thank you very much. Let me start. First of all, thank you very much. I think, was it Evans from Garissa, and particularly because it really. I appreciate the fact that even in a place like Garissa, you can already say you can feel the impact of some of the changes that we have made and the availability. To the point now where you're saying, okay, we are now getting blood, we want products. And really, for me, this is where we should be going. It really gives me energy for us to keep moving forward, because it says that, you know, we have made a step from where we used to be. Thank you very much, Evans. I think with regard to component preparation, this is an issue that we are looking at how to expand. We definitely have an expansion plan that is well in progress. As you know, it depends on resources. And so this is part of what we have to work slowly towards. But our intention is that within the next 2 years, really every single county should be able to have access within its satellite to component preparation. And all the equipment necessary, whether it's the centrifuges for doing that, and you know, if you're talking about platelets, then you're talking about agitators or incubators, or you know, whatever other machinery is required, fridges and freezers. I think the question around the donation culture, and that's why when we started speaking, one of the things I have repeatedly said is that our investment this year must be in mobilizing donors. We must start to talk about donation. We must start to create knowledge, information about donation. And even as we go forward, perhaps maybe my challenge to you would be, you know, community health workers, when they go and talk about malaria and they talk about HIV, is it possible for them to also talk about blood and about the need for donation? Because I think when we start to talk about it and make it very, very community-based, we are going to be more likely to begin to have more people aware and more people actually willing to donate. Because as you've seen from the numbers that I projected, people do want to donate when they are told and when they are engaged and when they are sensitized. Let me move on then to this issue around testing. It is not only unethical, it is against regulations to use rapid test kits for screening blood for use for transfusion. This is not something that should be done at all. So the next question is, what are we doing about it? When I gave my presentation, I said that there are 2 standards that are going for gazettement and compliance. And the first standard is the standard on establishment and management of blood transfusion services. Now, this standard obviously is based on the fact that we are recategorizing all establishments. And I was very clear that this includes every single establishment, whether it is in the private sector or in the public sector. By gazetting those standards and having the regulations, then compliance becomes a requirement. And therefore, moving forward, private facilities or public facilities, any facility, will be required to follow the standards and procedures. And where that does not happen, then there will be an issue of compliance that can be addressed through very many different forms and ways, some of which will be set out in the regulations, up to and including engaging the Kenya Medical and Dentist Practitioners Board, because once you have regulations, if you're not in compliance, then you do not the licensure can be taken there. So we will be providing registration for all blood transfusion services, and they will be required to then comply with the standards that will be gazetted. So I hope that answers the question, because we agree with you. It is an issue. It is not only unethical. It is against the guidelines, and nobody should be doing that because it actually compromises patient safety. Thank you.
Okay, thank you so much, Dr. Anduku, to the rest of the other discussants, that is Dr. Regina, Dr. Kariuki, for all your contributions, to all the participants. A round of applause to you all for participating, and very engaged discussions throughout this whole process. We'd like to just remind all of us, come next week, we are having a similar web series for the next, we have now about 4 weeks, or every Friday morning, you'll find us here discussing about blood and blood sector. Next week, we'll start on the hemovigilance series as well. And your contributions, just to see that the blood that is being provided, as alluded to by our colleague Philemon, that the issue about rapid kits, donor care, donor safety, patient safety, recipient safety, even the health workers, that is the nurses, the MLTs, who are all responsible to making sure that they are also kept safe during this whole process. We thank you for your attention and your contribution. We are 3 minutes past the hour, and see you next Friday. Thank you.
Thank you, Evelyn Chege and the whole team from KNTBS. On behalf of KNH, I've seen a lot of concerns raised on pharmacy people. So I've spoken to Dr. Ewak. Her main message is she's sending most of the message through GMAS. She will be able to facilitate at least 20 CPD points for most of the people. Most of the concerns are you have to be in the meeting for more than 30 minutes. If you do not meet the marking, it will have issues. And when you're registering, kindly register as a pharmacist. Otherwise, it cannot be picked from our end at because it's a different platform for CPD for pharmacies. I hope that answers most of the questions. However, you can still continue to raise your concerns on the email given on the email address for the CPD points for pharmacies. Kindly bear with us as we sort it out. As of next week on Monday, we'll have a session on epilepsy education. I hope to meet you there. Over to you.
Okay, so thank you very much. We can all leave at our own pleasure. Thank you. See you next week, and enjoy your weekend. Thank you.
Thank you. Bye-bye.